Imagine the scenario, right? A rugby player is sprinting down the field, and in a desperate final play, they reach out and just grab a fistful of their opponent's jersey.
Oh, classic mechanism.
Right, the opponent violently twists and rips away, and the player hears this distinct, sickening pop in their hand.
Yeah, that's never a good sound.
No, it's not. They look down, and suddenly the tip of their ring finger, it simply will not bend. It's entirely unresponsive.
Right, the system just failed.
Exactly. And usually when we talk about a medical diagnosis or, an anatomical structure, there's this expectation of robust, forgiving engineering.
Like a femur fracture.
Yeah. You break a femur, you put a massive titanium nail in it, and it heals. But when you step into the world of hand surgery, and specifically the flexor system of the hand, you are no longer dealing with simple carpentry.
Not at all. It is terrifyingly delicate.
It's a marvel of biological engineering,
Yeah.
and that pop the rugby player heard, that was the catastrophic failure of a system that operates with absolutely zero margin for error.
It really is a zero-sum game in the hand. I mean, the flexor system is entirely binary in its success.
What do you mean by binary?
Well, it either glides flawlessly with perfect excursion and minimal friction, or the entire mechanical apparatus just grinds to a halt. We want our biology to be adaptable, but the flexor anatomy, it offers no such luxury.
It's totally unforgiving.
Exactly. It is a highly specific, tightly packed landscape where structure dictates function down to the absolute millimeter.
And that absolute rigidity, right, that high-stakes anatomy is exactly why the flexor system is heavily, almost obsessively tested in surgical exams.
Oh, it's guaranteed to come up.
Guaranteed. So if you're listening to this deep dive right now, there is a very high probability you are prepping for the FRCS in trauma and orthopedics, or an equivalent exam like the DNB, MRCS, or EBOT.
And you're probably multitasking right now.
Exactly. You are probably in your car or at the gym or trying to squeeze in some revision while doing chores. So do not worry about pulling over to take notes.
We've got you covered.
We are pulling from the classic surgical atlases, Green's operative hand surgery, and decades of biomechanical research to give you exactly what you need. Our mission today is to synthesize this massive volume of information and just do the heavy lifting for you.
And because you're listening, we need to adapt to how auditory memory works.
Right. So when we hit the absolute vital numbers, the classification lists, and those critical exam discriminators, we are going to naturally reinforce them as we go. We will make sure those facts cross your radar twice.
Everything important gets said twice.
Exactly, so they lock in permanently.
That kind of spaced repetition is just essential. When you are sitting across from an examiner in a high-pressure viva, you don't have time to search your memory palace.
You really don't.
The anatomy, the biology of healing, and the surgical mechanics, they all need to be instantly automatically accessible.
Okay, let's unpack this. We need to start with a fundamental analogy to really visualize the engineering here. The easiest way to think about the flexor system is to picture a rope running through a series of rings.
A living rope.
Yes, the flexor tendon is a slick, living rope, and it has to travel from the forearm, across the wrist, through the palm, and down to the very tip of the finger. But it can't just take a straight line, right?
Right, because it has to stay anchored to the bone so it can actually bend the joints.
Exactly. To do that, the rope runs through a highly specific tunnel made of rings. Let's talk about those rings. What exactly is holding this rope in place?
So the structure we were talking about is the fibroosseous flexor sheath. It's a tunnel, and it's reinforced by two distinct types of pulleys.
And pulleys are just thickened bands of tissue, right?
Yeah, exactly. First, we have the annular pulleys. Think of annular like a ring or a solid band. There are 5 of them in each finger, numbered A1 through A5.
Okay, 5 annular pulleys, A1 through A5.
Right. And then interspersed between them, we have the cruciate pulleys. Cruciate meaning cross-shaped, like a delicate X of tissue.
And how many of those?
There are 3 of these, numbered C1 through C3.
I want to make sure we have that baseline architecture perfectly clear. That is 5 annular pulleys and 3 cruciate pulleys. 5 annular, A1 to A5, and 3 cruciate, C1 to C3.
Perfect. Now, the cruciate pulleys are fascinating because they allow the sheath to collapse like an accordion when the finger bends, preventing the tissue from bunching up.
Oh, that makes sense.
But the annular pulleys, they are the true workhorses. And just knowing there are 5 of them isn't enough for the exam. There is a beautifully simple geometric rule for remembering exactly where they sit on the skeleton.
I love a good rule. What is it?
The positioning alternates perfectly based on odd and even numbers. The odd-numbered annular pulleys sit directly over the joints of the finger, And the even-numbered annular pulleys sit directly over the shafts of the bones.
Okay, odd numbers over joints, even numbers over bones. Let's map that out specifically. Let's take the odd numbers first.
Sure, so that's A1, A3, and A5. These sit over the joints. The A1 pulley sits over the metacarpophalangeal joint, the MCP joint, right at the base of the finger in the palm.
Right. And A3?
The A3 pulley sits over the proximal interphalangeal joint, the PIP. And finally, the A5 pulley sits over the distal interphalangeal joint, the DIP.
So that's your odd numbers completely married to the joints. Then you look at your even numbers, which are A2 and A4.
Exactly. They sit firmly over the long shafts of the bones. The A2 pulley is anchored along the proximal phalanx, and the A4 pulley is anchored along the middle phalanx.
Let's lock that spatial map in right now because it's a brilliant way to visualize it. Odd-numbered pulleys sit over joints, that is A1, A3, and A5. Even-numbered pulleys sit over bones, that is A2 and A4.
It's a great spoken mnemonic.
Let's say it again. Odd over joints, A1, A3, A5. Even over bones, A2 and A4.
What's fascinating here is how that exact anatomical layout directly predicts clinical and biomechanical importance. The examiners love to ask, which two pulleys are the absolute most critical for maintaining the mechanical efficiency of finger flexion?
And the answer is the even-numbered ones, right? A2 and A4.
Yes, A2 and A4. Because they are anchored along the long, straight, rigid shafts of the phalangeal bones, they are the primary, heavy-duty structures holding that flexor tendon flat against the bone as the finger curls into a fist.
I want to push back on this a bit because I think it's easy to memorize A2 and A4 are important without actually understanding the physics behind it.
Go for it.
Let's say you are operating and you accidentally cut the A2 and A4 pulleys. The tendon naturally pops up away from the bone, taking a shorter path. Clinically, this is called bowstringing.
Right, bowstring.
But the muscle in the forearm is still firing. The tendon is still completely intact. It's just sitting higher up. Why does bowstringing mean the patient suddenly can't bend their finger properly?
That is the perfect question because it really comes down to the physics of moment arms and tendon excursion. Think about how a lever works.
Okay.
A moment arm is the perpendicular distance from the axis of rotation, the joint, to the line of action of the force, which is the tendon. Normally, the A2 and A4 pulleys keep the tendon hugging the bone.
So it's super close to the joint.
Exactly.
Yeah.
It stays very, very close to the joint's central axis. Because the radius of that turn is incredibly tight, a very small pull from the muscle, a short excursion of the tendon, creates a massive degree of rotational movement at the joint.
Right. It's a highly efficient system. A
Yeah.
tiny millimeter of pull equals a lot of degrees of bend.
It's highly efficient. But if you lose A2 and A4, the tendon lifts away from the bone. It literally looks like the string of an archery bow spanning across the curve of the finger.
Hence the name bowstringing.
Exactly. By lifting away, you have just massively increased the distance between the tendon and the joint's axis of rotation.
Yeah.
You have vastly increased the moment arm.
And why is that bad?
Because now, suddenly, the muscle has to pull a huge amount of tendon, a massive excursion, just to get a tiny bit of joint rotation.
Yeah.
And here is the physiological limit. The muscle belly in the forearm simply doesn't have enough contracting length to take up all that new slack.
So the muscle fires, it fully contracts, it puts the effort in, but all it does is pull the tendon taut across that new lazy bowstring path.
Right.
It runs out of gas before it can actually rotate the joint.
Precisely. You put the effort in, but you get vastly less bend out. The mechanical disadvantage is so great that you lose active flexion, resulting in a stiff, claw-like finger.
Wow.
So if a multiple-choice question offers you A1 and A2 or A1 and A4 as the most important pulleys, you reject them immediately. The critical biomechanical anchors are A2 and A4.
So if a candidate takes away just one core principle from this architectural segment, it has to be this. There are 5 annular and 3 cruciate pulleys. The even-numbered A2 and A4 are the critical ones, sitting over the bones, and if you lose them, the tendon bowstrings and destroys your mechanical advantage.
That's a perfect summary.
I want to say that one more time to cement it. 5 annular and 3 cruciate pulleys. A2 and A4 are critical, lose them, and the tendon bowstrings.
It is a perfect synthesis of anatomy and physics.
Okay, we know the rings that hold the rope. Now let's zoom out and map out the entire neighborhood that this rope travels through. We need to talk about the flexor zones.
The hand is divided into distinct anatomical zones to categorize injuries, predict outcomes, and guide surgical approaches. And the numbering system runs strictly from distal to proximal.
From the fingertip down towards the elbow.
Exactly. That means we start at the very tip of the fingertip and work our way up into the forearm. There are 5 zones for the long fingers. the index, middle, ring, and little finger.
And the thumb.
The thumb, because of its unique evolutionary anatomy and fewer joints, gets its own separate set of 3 zones.
Let's lock in those numbers right away. The flexor zones run distal to proximal, numbered 1 to 5 for the fingers. The thumb has its own 3 zones. Again, distal to proximal, 1 to 5. Thumb has 3. Let's take a walk through these neighborhoods, starting out at the very tip of the finger, zone I.
Zone I is the most distal territory.
Yeah.
Geographically, it runs from the insertion of the superficialis tendon on the middle phalanx all the way out to where the profundus tendon finally inserts on the base of the distal phalanx. Because the superficialis tendon has already ended and anchored itself before this point, Zone 1 is exclusive territory. It contains only one tendon, the flexor digitorum profundus.
So zone 1 is FDP only, just the one deep tendon making it to the finish line. Then we move proximally, moving inward into zone 2, and this is the famous one, the notorious one.
It is arguably the most famous square inch in all of orthopedic surgery. Zone 2 is historically referred to as no man's land.
No man's land.
Geographically, it begins at the proximal edge of the A1 pulley, which roughly correlates to your distal palmar crease, and it runs all the way out to the insertion of the FDS on the middle phalanx.
And what's inside it?
In this specific neighborhood, both the superficialis and the profundus, the FDS and FDP, are traveling together inside a single, unyielding, tightly packed fibro-osseous sheath.
No man's land. I've always loved that moniker, but why exactly did Sterling Bunnell give it that name back in the early 20th century? It sounds incredibly bleak.
It was incredibly bleak. For decades, the results of primary tendon repairs in this specific zone were so universally disastrous that textbooks instructed general surgeons to never even attempt a repair here.
Seriously, just don't touch it.
They were explicitly told it was a no man's land where no surgeon should tread. If a patient cut their finger in zone 2, the standard of care was simply to wash it, close the skin, let the tendon ends retract, wait several months, and refer them to a specialist for a highly complex tendon graft later on.
And the reason for that failure rate is purely mechanical, right? Because it's 2 living ropes shoved inside one tiny inflexible tunnel.
Exactly. You have 2 tendons, the FDS and the FDP, that absolutely must glide smoothly and independently of one another, but they are packed tight into this rigid fibro-osseous tunnel.
So any swelling is a disaster.
Right. If a trauma occurs and a surgeon goes in and puts bulky stitches into those tendons, it disrupts that perfect smooth surface. Furthermore, the body's natural response to trauma is to create scar tissue.
Which ruins the glide.
Completely. In zone 2, that scar tissue acts like biological superglue. It tethers the FDS to the FDP and glues both of them to the inner wall of the sheath. The finger freezes solid.
But we fix them now, right?
We do. Modern microscopic techniques, better suture materials, and early motion protocols have revolutionized this, allowing us to repair them primarily, but the underlying biological challenge of zone 2 remains immense.
That makes perfect sense. Okay, moving further inward, crossing the palmar crease into the palm itself, zone 3.
Zone 3 is the true palm. It runs from the distal edge of the transverse carpal ligament, which is the exit of the carpal tunnel, out to the start of the A1 pulley.
And what's the key fact here?
The absolute vital landmark fact for the exam here isn't just about tendons, it's about a muscle. Zone 3 is exactly where the lumbrical muscles originate. They are unique because they literally sprout off the sides of the moving FDP tendons right here in the middle of the palm.
I want to highlight that. The lumbricals originate from the FDP tendons in zone 3. That specific piece of anatomical trivia is going to be incredibly important for the mechanical failures we discuss later on.
Keep it in mind.
So palm is zone 3, home of the lumbrical origin. Then we hit the wrist, zone 4.
Zone 4 is the carpal tunnel itself. This is a massive anatomical bottleneck, and you need to know its contents cold for any exam.
What are the boundaries?
It is a rigid space bounded by the carpal bones deep and the transverse carpal ligament superficially. Inside, it contains exactly 9 tendons and 1 nerve.
9 tendons, 1 nerve.
That breaks down as 4 flexor digitorum superficialis tendons, 4 flexor digitorum profundus tendons, and 1 flexor pollicis longus, the FPL for the thumb. That makes 9 tendons in total, and crucially, the median nerve.
That is a classic high-yield list. Let's make sure it sticks. Zone 4 is the carpal tunnel. It contains exactly 9 tendons and 1 nerve. That is 4 FDS, 4 FDP, 1 FPL for the thumb, plus the median nerve. Let me run that one more time. 9 tendons, 4 FDS, 4 FDP, 1 FPL, plus a median nerve. Okay, and finally, getting out of the bottleneck. Zone V.
Zone V is everything proximal to the carpal tunnel. It is the distal forearm, stretching up into the musculotendinous junctions and the large muscle bellies themselves.
What kind of injuries happen here?
Injuries here are often catastrophic wrist lacerations, sometimes called spaghetti wrist, because of the sheer number of cut tendons, nerves, and vessels. But they actually have a better prognosis for tendon gliding than Zone 2 because they aren't trapped in that tight sheath.
Let's wrap this geographical map up. If a listener only anchors onto a few key points from this segment, it should be this. Zones run distal to proximal, numbered 1 to 5.
Right.
Zone 1 is FDP alone. Zone 2 is the notorious no man's land, containing both tendons in a tight sheath. Zone 4 is the carpal tunnel, packed with 9 tendons and the median nerve.
A perfect summary.
I'll hit that once more. Zones run distal to proximal, 1 to 5. Zone I is FDP alone. Zone 2 is no man's land with both tendons. Zone 4 is the carpal tunnel with 9 tendons and the median nerve.
That maps the territory perfectly. It gives us a framework to understand where injuries happen and why they matter.
Here's where it gets really interesting. I want to zoom back in on Zone 2, because it's not just the fact that both tendons are crammed in there together that makes it complex. It's that they actually perform this incredibly intricate anatomical dance.
They really do.
The superficialis and profundus tendons literally swap spatial positions.
They do, and it truly is a masterpiece of evolutionary engineering. If you trace the tendons in the palm, approximately in Zone 3, the FDS, the superficialis, lies on top.
Right.
It is superficial to the palm, just as its name promises.
Yeah.
The FDP, the profundus, lies deep underneath it, closer to the bone. But the profundus, the deep tendon, is the one that is tasked with traveling all the way to the absolute tip of the finger to bend the distal phalanx.
Wait, so the profundus is trapped underneath the superficial atlas, but it has to get past it to reach the fingertip. How does it bypass a solid tendon sitting directly on top of it?
Right in the heart of Zone 2, roughly over the proximal third of the proximal phalanx, the superficialis tendon does something remarkable. It actually splits completely in half.
Just unzips.
Yes, it divides into 2 distinct slips. We call this anatomical decussation Camper's chiasma. These 2 split slips of the FDS dive downward, pass completely around and behind, or dorsal, to the FDP tendon.
Wow.
They rotate 180 degrees and then reunite beneath the FDP to anchor themselves firmly onto the base of the middle phalanx.
I love this visual. It's like the superficialis literally unzips itself, opens the door, and gracefully lets the profundus walk right through the opening.
That is exactly the mechanics of it. It opens a door, the FDS splits, wraps around the back of the FDP, rejoins itself, and stops its journey at the middle phalanx.
And the FDP just keeps going.
Meanwhile, the FDP just marches straight through that newly opened doorway and carries on its path out to the distal phalanx. So by the time you reach the end of the finger, their relationship is entirely flipped. The deep has become superficial, and the superficial has become deep.
And just to hammer the geography for the exam, this crossing, this incredible structure called Camper's chiasma, happens entirely within which zone?
It is exclusively a Zone 2 structure. The decussation of the FDS defines the biomechanics of no man's land.
Okay, here is the synthesis for this anatomical marvel, the main takeaway. In Zone 2, the FDS splits into 2 slips, which is Camper's chiasma, and passes around the FDP to insert on the middle phalanx, while the FDP carries on through the split to the distal phalanx.
Exactly right.
Let's hear that again. In Zone 2, the FDS splits into 2 slips. Camper's chiasma passes around the FDP to insert on the middle phalanx, while the FDP carries on out to the distal phalanx.
Excellent. That completely covers the resting, uninjured anatomy. We have the architecture built.
Let's do a quick mid-episode recap just to lock in the first half before things get bloody.
Good idea.
So we have the rings holding the rope, 5 annular and 3 cruciate pulleys, odd numbers over joints, even over bones. A2 and A4 are the critical heavy lifters. Then the zones, running 1 to 5. Zone 1 is FDP alone. Zone 2 is the tight no man's land. Zone 3 is the palm with the lumbrical origin. Zone 4 is the carpal tunnel with 9 tendons and the median nerve. And finally, in Zone 2, we have Camper's chiasma, where the FDS splits to let the FDP through.
You've got it all.
Which means it is time to transition. We have laid down the pristine anatomy, but in an orthopedic exam, things don't stay pristine for long. Disaster strikes.
The rope is cut.
Exactly. The rope is cut, the patient is lying on your table in theater, and you have to repair this delicate mechanism. When the examiner asks you what primarily determines if your repair is going to hold together or if it's going to snap the second the patient starts rehab, what is the fundamental answer?
We are entering the realm of biomechanics here. The single most testable fact regarding flexor tendon repair biomechanics is this. The absolute tensile strength of the repair is directly proportional to the number of core suture strands that cross the repair site.
I'm jumping on that. The strength of the repair is directly proportional to the number of core suture strands crossing the repair site, the core strands.
Exactly. If you perform a traditional two-strand repair like an old-school modified Kessler, it is fundamentally weak. It cannot withstand the forces of active motion.
So you need more strands.
Right. If you upgrade your technique to a 4-strand or a 6-strand repair, passing more threads of suture material across that gap, the construct gets progressively, predictably stronger. And that absolute mechanical strength is what dictates how aggressively and how early your hand therapist can start moving that finger.
Let me throw an exam trap at you because I've seen candidates get tied in knots over this. A multiple choice question will try to distract the candidate by asking about the configuration of the suture. They'll ask, does the number of grasping loops or locking knots affect the tensile strength of the repair?
It's a very clever distractor, and you have to understand the physics to navigate it. Surgeons use specific stitches, like modified Kessler, Tajima, or cruciate stitches, which feature locking or grasping loops.
And what do those loops actually do?
Now, those loops are vital because they ensure the thread actually grips the longitudinal collagen bundles of the tendon. If you just put a straight stitch in, it would slide out under tension like a cheese wire cutting through butter. So the loops prevent pull-out.
Okay, so loops prevent pull-out, but what about strength?
But when they ask what dictates the absolute tensile strength, how much sheer pulling force the repair can take before the thread itself snaps or the whole construct fails, the answer they want is the strand count. The number of physical strands crossing the gap is the dominant variable for strength.
So, core strands dictate the strength. That is the engine of the repair. But what else can we do surgically to optimize the mechanics of this mended rope?
There are 3 other key technical elements you must mention to an examiner. First, you add an epitendinous suture.
What does that look like?
This is a very fine, continuous running stitch that goes all the way around the outside periphery of the tendon repair.
Like a microscopic hem on a pair of trousers?
Precisely. Its primary job is to smooth down the bulky, frayed edges of the cut tendon so it can glide smoothly through that tight fibro-osseous sheath without catching.
Does it add strength, too?
Yes. Biomechanically, because it shares the load at the periphery, the epitendinous suture adds about 10 to 20% more strength to your overall core repair.
Okay, epitendinous stitch adds 10 to 20% strength. Second point.
You absolutely must avoid gapping. When you tie your knots, the 2 ends of the cut tendon must sit flush against each other. If your tendon ends sit more than 2 millimeters apart, the repair is effectively failing biologically.
Why is a 2 millimeter gap so bad?
A gap weakens the overall physical construct. It allows disorganized scar tissue to infiltrate the space, and it drastically increases the risk of a late rupture.
No gaps greater than 2 millimeters. And the third crucial element.
Meticulous, gentle, atraumatic handling of the tendon ends. If you grab the delicate edge of the tendon with heavy-toothed forceps and crush it while trying to sew it, you cause localized tissue necrosis.
You literally kill the cells.
You kill the cells. That massive trauma signaled the body's immune system to send in a flood of inflammatory cells, which directly drives the formation of dense, restrictive adhesions.
Okay, here's another classic debate that examiners love to bring up. Let's say you've done a beautiful 4-strand core repair, a neat epitendinous running stitch, there is absolutely 0 gap, and you handled the tissue with the utmost care.
Sounds like a great repair.
The tendon looks perfect. Do you have to meticulously sew that tight little fibro-osseous sheath back together over the repaired tendon?
Emphatically no.
Yeah.
That is a historic debate that the exam still loves to test to see if you are current with the literature.
Why did they ever do it?
In the past, surgeons believed repairing the sheath was mandatory to restore a barrier and hold synovial fluid around the tendon for nutrition. However, the evidence now clearly shows that routine sheath closure does not definitively improve functional outcomes.
And it probably makes things worse, right?
Right. You can often make the tunnel far too tight, causing strictures and restricting glide. Sheath repair is not mandatory.
Right, let's synthesize the mechanics of the repair. The main takeaway. Repair strength tracks directly with the number of core strands crossing the site. You add an epitendinous suture for 10 to 20% more strength, avoid any gapping, handle the tendon gently to prevent necrosis, and you do not have to close the sheath.
Perfect.
I'll repeat those pillars. Repair strength tracks with the number of core strands, add an epitendinous suture, avoid gapping, handle gently, and you don't have to close the sheath.
So, mechanical repair is in place. You've used thread to artificially reapproximate the anatomy, but suture material doesn't heal. It just holds things in place. Now, biology has to take over.
Which brings us to the fascinating cellular biology of how tendons actually heal. And in the literature, there is a clear good guy and a bad guy in this story. We are talking about intrinsic healing versus extrinsic healing.
Right. If we connect this to the bigger biological picture, a tendon isn't just a dead piece of string. It's a vibrant, living tissue. Intrinsic healing is the cellular pathway we desperately want to encourage.
How does that work?
This process is driven by tenocytes, the native specialized tendon cells that live inside the tendon itself. Now, because tendons have a notoriously poor blood supply, especially in zone 2, these tenocytes rely on a process called imbibition.
Imbibition, like drinking.
Yes, exactly.
Yeah.
They get their nutrition through the diffusion of synovial fluid that bathes them inside the sheath. If the tendon heals intrinsically, it heals itself from the inside out. The surface stays incredibly slick, the collagen aligns perfectly, and the tendon keeps gliding.
Okay, intrinsic healing is the good guy. Tenocytes doing the work from the inside. But what about the bad guy? Extrinsic healing.
Extrinsic healing is the biological enemy of hand surgery. This occurs when the body, sensing trauma, decides it cannot rely on the slow internal tenocytes.
So it brings in outside help.
Exactly. It relies on the tissues surrounding the tendon, the sheath, the subcutaneous fat, the local blood vessels to aggressively bridge the gap. Inflammatory cells, blood vessels, and fibroblasts from the outside aggressively invade the repair site.
That sounds like a robust healing response. Why is it so bad?
Because it lacks finesse. These extrinsic cells lay down a massive disorganized block of scar tissue. They literally glue the repaired tendon to the inner wall of the sheath.
Ouch.
Those bands of scar tissue are called adhesions. The tendon gap heals, sure, but the tendon is now permanently tethered to the wall of its tunnel. The finger becomes completely stiff. You've achieved continuity, but you've lost all function.
So clinically, as surgeons and therapists, how do we promote the good guy intrinsic healing and shut down the bad guy extrinsic healing?
The answer is mechanical stress, specifically early controlled movement. When we implement early motion protocols, the physical gliding action of the tendon literally wipes away and breaks up those fragile early extrinsic vascular adhesions from the sheath.
Oh, that makes total sense.
Simultaneously, the mechanical tension placed on the tendon stimulates the internal tenocytes through a process called mechanotransduction. It signals them to ramp up their intrinsic collagen production and align the new fibers along the lines of stress.
It's basically Wolff's Law for tendons. The tissue remodels along the lines of physical stress. But to understand when it is safe to move it, we need to understand the biological timeline. What are the phases of tendon healing?
There are 3 distinct biological phases you need to know. First is the inflammatory phase, which kicks in immediately and lasts for the first few days.
What happens then?
This is when macrophages are clearing out debris and the tissue is at its weakest. Second is the fibroblastic phase, often referred to in the literature as the proliferative phase.
When is that?
This runs from roughly day 5 out to about 4 weeks. This is the critical window where fibroblasts are actively proliferating, laying down early type 3 collagen to bridge the gap.
And the final phase?
Third is the remodeling phase, which takes months, where that disorganized type 3 collagen is slowly replaced by robust type I collagen, maturing and cross-linking to maximize strength.
Let's lock in those phases and their timelines, because the exam will test your knowledge of when a tendon is most vulnerable. The inflammatory phase is the first few days. The fibroblastic or proliferative phase is from day 5 to 4 weeks. That's when collagen is being laid down. And the remodeling phase takes months.
Yes.
Let's reiterate that. Inflammatory is the first few days. Fibroblastic is day 5 to 4 weeks. Remodeling is months.
And here's the ultimate synthesis for the exam.
Mm-hmm.
They will present a scenario and ask you when your early motion rehabilitation protocols are doing their most vital, biologically important work.
And the answer?
The answer they want is the fibroblastic phase.
So the takeaway principle here. Intrinsic healing is the goal, driven by tenocytes. Extrinsic healing gives you stiff adhesions. Early motion pushes the biology toward intrinsic, and those early motion protocols are doing their critical work in the fibroblastic phase.
Spot on.
Let's cement that. Intrinsic healing is good. Extrinsic causes adhesions. Early motion promotes intrinsic healing, and this motion is most critical during the fibroblastic phase.
Which logically brings us to the next massive clinical problem.
Yeah.
We know we absolutely need to move the tendon to force intrinsic healing and prevent adhesions.
Right.
but the tendon is currently only being held together by a few strands of microscopic surgical thread. How on earth do we move the finger safely without snapping our repair?
It's a terrifying tightrope walk. We have to thread the needle between permanent stiffness on one side and catastrophic rupture on the other. This is where we look at the two classic rehabilitation protocols that revolutionized hand surgery, Kleinert versus Duran.
Yes, and candidates mix the mechanics of these up all the time.
Why do they mix them up?
Because both protocols involve a bulky dorsal splint, and both involve moving the finger early in the healing process. But they are fundamentally mechanically different in how they achieve that motion.
Let's start with the older of the two, the Kleinert protocol.
The Kleinert protocol is fundamentally dynamic.
Dynamic, meaning the patient is actually using their own active muscle power for part of the exercise?
Exactly. In a classic Kleinert protocol, the patient wears a dorsal blocking splint on the back of their hand to protect against sudden accidental hyperextension.
And the dynamic part?
Crucially, there is a rubber band attached to the fingernail of the injured digit, which runs down to a hook on the wrist or forearm. The patient uses their own uninjured extensor muscles on the back of the forearm to actively straighten or extend the finger against the resistance of that rubber band.
Okay, so they actively push it straight.
Then, they are instructed to completely relax their hand, and the tension of the rubber band passively pulls the finger back down into a curled, flexed position.
So, active extension, powered by the patient's own extensor muscles, followed by rubber band-assisted passive flexion. That is the definition of Kleinert. Active extension, rubber band, passive flexion.
You got it.
Now, the exam often asks for the specific geometrical angles of that dorsal blocking splint in a Kleinert setup. What are they?
The exam wants these specific numbers to ensure you understand the protective posture. The wrist is held in slight flexion, usually around 20 to 30 degrees.
And the nulls?
The metacarpophalangeal joints, the MCPs in the palm, are held at 40 to 60 degrees of flexion. This protects the repair by taking tension off the flexor system. And the interphalangeal joints, the IPs, are left completely free to move.
Let's reinforce those splint numbers for the Kleinert setup. Wrist in slight flexion. MCP joints 40 to 60 degrees flexed. IP joints free.
Correct.
Again, MCPs flex to 40 to 60 degrees and IP joints are free. Okay, so if Kleinert is dynamic, contrast that with the Duran protocol.
Duran is a purely passive protocol. There are no rubber bands. Within the confines of that same dorsal blocking splint, the patient uses their other uninjured hand, or a trained hand therapist helps them, to physically grab the injured digit.
And then what?
They passively push it into flexion and then passively pull it into extension. The injured flexor muscle in the forearm is never instructed to fire. It remains entirely relaxed throughout the exercise.
So Duran is passive flexion, passive extension. You are just manually pumping the joint to glide the tendon without firing the engine.
Correct. It's passive-passive.
All right, I want to throw a massive classic curveball that the examiners absolutely love to use to test your clinical judgment. We have just spent the last, 20 minutes meticulously establishing that early motion is the holy grail.
It is the holy grail.
It prevents extrinsic adhesions, it aligns collagen, it promotes intrinsic healing. Okay, so a 5-year-old child comes into your clinic. They have a zone 2 flexor tendon laceration. You take them to theater. You do a flawless, beautiful 4-strand core repair. What is your postoperative rehabilitation protocol?
You completely abandon everything we just talked about regarding early motion. You put that child in a cast, and you strictly immobilize them.
Wait, what? Why? Won't they get completely stiff? Won't they develop massive extrinsic adhesions that ruin the repair?
They might develop some stiffness initially, but this raises a critical question about patient compliance versus biological reality. A 5-year-old child fundamentally cannot understand the nuances of a complex dynamic protocol.
That's very true.
If you put a rubber band on a toddler's finger, they will immediately yank on it. If you ask them to do gentle passive motion, they will get scared and forcefully fire their flexor muscles to fight you. The rupture rates for early motion protocols in young pediatric patients are unacceptably high.
Oh, I see.
Furthermore, children's tissues have a remarkable, almost magical capacity to remodel over time, and their risk of permanent debilitating stiffness is vastly lower than in adults. Therefore, the safest, most effective route is strict immobilization to protect the repair from the child themselves.
However, there is a biological time limit on that immobilization, right? You can't just leave them in a cast forever.
Yes. You immobilize them, but you do not immobilize them beyond 4 weeks.
Because 4 weeks is the limit.
Right. If you leave a child casted for 6 or 8 weeks, you cross a biological threshold where the scar tissue becomes too dense and
Yeah.
their final range of motion severely and permanently deteriorates.
Let's lock in this pediatric trap. For a young child under 5, you immobilize the repair, but you do not immobilize beyond 4 weeks.
Correct.
Again, for the young pediatric patient, immobilize them, but absolutely not beyond 4 weeks.
That is exactly the nuance the examiners are looking for. It shows you understand both the biology and the practical reality of treating humans.
Let's summarize the rehab philosophies. The main takeaway here, Kleinert is a dynamic protocol using active extension and rubber band passive flexion. Duran is a passive-passive protocol, and the young pediatric patient gets strictly immobilized, but never beyond 4 weeks.
Perfect recap.
I'll run through that one more time. Kleinert is dynamic with active extension and rubber band passive flexion. Duran is passive-passive, and the young child is immobilized, but not beyond 4 weeks.
Let's pause for another quick recap before we move on to scenarios.
Great idea. Mid-episode recap number 2. We discussed repair strength. It's all about the core strands. You add an epitendinous suture for 10 to 20% more strength. Intrinsic healing is driven by tenocytes and is good. Extrinsic healing is driven by fibroblasts and causes bad adhesions. Early motion during the fibroblastic phase promotes intrinsic healing. Kleinert is dynamic with rubber bands. Duran is passive. And kids get immobilized for a max of 4 weeks.
Perfect. We have now covered the resting anatomy, the biomechanics of the repair, the cellular biology of healing, and the rehabilitation.
Which means we are ready to dive into some of the most fascinating surgical and clinical scenarios. Let's look at a practical surgical trap that comes up on the exam all the time.
Lay it out.
You are operating. The patient has a clean laceration of the FDP tendon in zone 2. But because the muscle in the forearm naturally contracted at the moment of injury, the proximal end of the cut tendon has retracted all the way down the finger, pulled out of the sheath, and is now hiding somewhere deep in the palm.
That happens quite often.
You have to get it back into the finger to repair it. What is the classic surgical trap here?
The trap is impatience and frustration. The completely wrong way to retrieve that retracted tendon is to take a tendon retriever or heavy metal forceps, shove them blindly down the delicate fibroosseous sheath, grab whatever soft tissue you can find in the palm, and aggressively yank it distally back into the finger.
Which goes back to what we said earlier about the biology of the sheath and atraumatic handling.
Exactly. The inside of that sheath is lined with a microscopic layer of synovial cells that provide the nutrition for intrinsic healing. Every single time you scrape those heavy metal forceps against the inner wall of the sheath, you are destroying that synovial lining.
And crushing the tendon.
Right. Every time you blindly crush the end of the tendon trying to grip it, you are causing cellular necrosis. If you do this, you are literally guaranteeing a massive extrinsic inflammatory response. You will create severe adhesions, and the surgery will be a functional failure even if the suture holds.
So how do we coax this retracted rope back into its tunnel elegantly and biologically?
The correct, examinable technique is to use a simple pediatric feeding catheter.
A feeding catheter.
Yes. You take a very fine, flexible, smooth plastic catheter and pass it gently up through the empty sheath from the fingertip, distal to proximal. When the tip of the catheter emerges in the palm, you locate your retracted tendon, put a very fine suture through the tip of it, and sew it to the end of the catheter.
Oh, that's clever.
Then you simply go back to the distal end of the finger, take hold of the catheter, and gently pull. It softly draws the tendon through the sheath, following the perfect anatomical path, without any scraping or crushing.
It's brilliant. It's like threading a needle, but in reverse. You use the catheter as a guide wire.
Precisely. It is entirely atraumatic. It deeply respects the synovial biology we discussed earlier, and it is the only answer you should ever give an examiner when asked how to retrieve a retracted tendon.
So the takeaway for surgical technique. Retrieve a retracted FDP by suturing it to a fine pediatric catheter and drawing it distally. Do not blindly grab it with metal instruments.
Exactly.
I'll state that again. Retrieve a retracted FDP using a fine catheter and drawing it distally. Never blindly grab it with instruments.
From surgical technique traps, let's transition to some of the classic clinical presentations. There are specific injury patterns that are absolute staples on the written paper and the Viva.
Let's circle all the way back to the hook of our deep dive. The staple of sports medicine. A rugby player tackles an opponent, grabs a fistful of their jersey, the opponent violently rips away, and the player comes to the sideline saying they felt a pop and can't bend their fingertip anymore.
This is the classic jersey finger. The pathomechanics of this injury are highly specific, and you must understand the physics.
Walk us through it.
The player has a forcefully gripping hand, meaning they have active, maximal contraction of the flexor digitorum profundus muscle. Their engine is firing at 100%. Then, an overwhelming, violent hyperextension force is applied directly to that distal phalanx as the opponent's jersey is ripped away.
So the force pulls it the wrong way.
Exactly. The physical force of the opponent exceeds the ultimate tensile strength of the tendon's insertion into the bone, and the FDP violently avulses or tears away from the distal phalanx.
Out of all the fingers on the hand, which one is statistically most commonly affected by a jersey finger?
It is overwhelmingly the ring finger. Roughly 75% of all jersey fingers occur in the ring finger.
Why the ring finger?
Biomechanically, when you make a power grip, the ring fingertip is slightly more prominent, exposing it to the greatest load during that hyperextension force.
And clinically, if you examine this player on the sideline, what do you see?
The hallmark sign is that the patient will be entirely unable to actively flex the DI key joint of that ring finger. You ask them to make a fist, and the fingertip just stays rigidly straight.
What if you get an X-ray?
Notably, if you send them for an initial X-ray, it is very often completely normal. The exam will try to trick you with this. A normal X-ray does not rule out a jersey finger because in many cases it is a pure soft tissue avulsion without a bony fracture fragment.
So if the X-ray is clear, do you just put them in an aluminum splint, tell them to rest, and send them home?
Absolutely not. The treatment is definitive surgical repair to physically re-anchor the tendon to the distal phalanx. And to guide the urgency and the specific surgical approach of that repair, you must know the Leddy and Packer classification.
Leddy and Packer.
It dictates everything based on how far the tendon has retracted, and crucially, what that retraction does to the tendon's blood supply.
Okay, let's lay out the Leddy and Packer classification. I know this is heavily tested.
It's the three-part classification based entirely on anatomy and ischemia. Let's start with type I.
Where does it go?
Type 1. The tendon violently retracts all the way down the finger, out of the sheath and into the palm. Now, inside the finger, the tendon is tethered by tiny blood vessels called the vincula.
And what happens to them?
Because a type I injury has pulled so far back, it violently shears off and destroys both the vincula longa and brevia. Its blood supply is entirely lost. Without blood, the tendon will begin to necrose, swell, and mechanically contract very quickly.
So it's a ticking clock.
Therefore, type I requires urgent surgical repair within about 7 to 10 days before the muscle permanently shortens.
Okay, that makes perfect biological sense. Type I retracts to the palm, the blood supply is lost, so you must fix it in 7 to 10 days. Got it. What about type 2?
Type 2, the tendon avulses and retracts, but it stops at the level of the PIP joint. It is physically caught and held there by an intact vinculum.
So it still has blood?
Because the vinculum is intact, a significant portion of its blood supply is preserved. Because the tendon isn't completely ischemic, you have a bit more time to operate before it fibroses, but it still requires formal surgical reattachment.
And finally, type 3.
Type 3 is where the tendon avulses, but it pulls off a relatively large fragment of bone from the base of the distal phalanx. Because this bony fragment is bulky, it gets physically wedged and trapped at the very first tight ring it encounters as it tries to retract.
Which pulley is that?
That is the A4 pulley. It physically cannot retract any further.
Let's lock in the Leddy and Packer classification right now. Type 1 retracts to the palm, blood supply is lost, fix urgently in 7 to 10 days. Type 2 retracts to the PIP joint, held by an intact vinculum. Type 3, a bony fragment avulses and physically catches at the A4 pulley.
Perfect.
I'll run through that once more. Type 1 retracts to palm, blood supply loss, fix 7 to 10 days. Type 2 retracts to PIP, held by intact vinculum. Type 3, bony fragment catches at A4.
That is the gold standard classification for FTP avulsions.
Let's look at a second classic clinical scenario. Let's say a patient comes into your clinic. 4 months ago, they suffered a deep glass laceration at the base of their thumb. They didn't seek medical attention, they just ignored it. Right. Now, they are sitting in front of you. They have absolutely no active flexion at the interphalangeal joint, the IP joint of the thumb. But critically, when you take their thumb and gently bend it yourself, it has full, smooth, perfect passive motion.
Okay, so we're dealing with a chronic, neglected laceration of the flexor pollicis longus, the FPL tendon.
Why does passive motion matter?
The key discriminator in your exam prompt is that phrase, full passive motion. That tells you something incredibly important about the joint biology. It tells you the IP joint itself has not stiffened, It hasn't developed severe, rigid capsular contractures.
So the joint is fine.
The joint is a viable, supple, healthy mechanical hinge. It just doesn't have a biological engine connected to it anymore.
I want to push back on the surgical plan here. If the joint is perfectly healthy, and we know the tendon is just cut, why can't we just open the thumb up, find the two ends of the FPL, and do a primary repair like we discussed earlier?
Because of the timeline. It has been 4 months. In those 4 months, the FPL muscle belly up in the forearm, having lost all of its resting tension, has steadily contracted, scarred, and permanently shortened.
The muscle just shrinks.
Yes, the proximal end of the tendon has retracted far up into the wrist. If you tried to grab that shortened muscle and pull it all the way back down to the thumb, you would be operating under immense, biologically impossible tension. The sutures would rip through the tissue instantly.
Oh, yeah, okay.
A primary repair at 4 months is completely off the table.
Okay, primary repair is out because the muscle is ruined. What about just fusing the IP joint of the thumb so it's at least stable for pinch grip?
A fusion is a salvaging procedure. It fundamentally throws away motion. The exam prompt specifically told you the patient has perfect supple passive motion. The cardinal rule of hand surgery is that you never sacrifice a perfectly moving joint if you have a biological way to power it.
So we can't use the old engine, and we don't want to weld the hinge shut. We need a new engine.
Exactly. We need a tendon transfer. And the gold standard, examinable answer for a chronic FPL laceration with a supple joint is to transfer the FDS tendon of the ring finger.
The ring finger FDS.
You take the superficialis tendon from the ring finger, reroute it across the palm to the thumb, and insert it onto the distal phalanx in place of the ruined FPL.
Why the ring finger FDS? Why not the index or middle?
Because the ring finger FTS has an independent muscle belly that provides excellent excursion, meaning it can pull the right distance. And critically, the ring finger tolerates the loss of its superficialis extremely well because it still has its intact profundus tendon to provide power grip.
So it's a fair trade.
The thumb gets a powerful, perfectly tensioned new engine to restore flexion, and the donor finger suffers minimal deficit.
Ring finger FDS transfer. That is an incredibly elegant solution to a complex biological problem. Let's summarize these two clinical presentations. The core takeaway. A jersey finger is an FDP avulsion, most commonly in the ring finger, which must be treated surgically. Meanwhile, a chronic FPL laceration with full passive motion requires a ring finger FDS transfer.
Exactly right.
I'll reiterate that. Jersey finger is an FDP avulsion, usually the ring finger, treated surgically. A chronic FPL laceration with full passive motion gets a ring finger FDS transfer.
We are entering the final major segment of our deep dive, and this is where the pristine anatomy we laid out earlier creates some truly fascinating, almost unbelievable mechanical paradoxes when it is injured.
We promise you two beautiful failures, lumbrical-plus and quadriga, and both of these completely bizarre clinical presentations trace directly back to one single anatomical fact we flagged way back when we were discussing Zone 3.
The lumbricals. Remember, we said the lumbrical muscles are unique. They do not attach to bone at their origin.
Right, they attach to the tendon.
Instead, they arise directly off the sides of the flexor digitorum profundus tendons in the middle of the palm. But where do they go? They travel distally, pass volar to the transverse metacarpal ligament, and they insert into the radial lateral band of the extensor mechanism on the back of the finger.
This is the anatomical bridge. It connects the front of the hand to the back of the hand.
It is the only place in the human body where a muscle bridges entirely between two antagonistic systems. It literally starts on a flexor tendon, and it ends on an extensor tendon. Under normal, healthy circumstances, it balances the finger, helping to flex the MCP joint while simultaneously extending the IP joints.
So what does this all mean when things go wrong? Let's start with failure number 1, lumbrical-plus syndrome. What does it look like clinically?
The patient is sitting across from you in clinic. You ask them to make a tight fist. As they squeeze their hand shut, firing their flexor muscles in their forearm, the affected finger does something completely paradoxical.
Does it not bend?
Worse. Instead of curling inward to make a fist, the PIP and DIP joints of that finger aggressively straighten out. They extend. The harder the patient tries to flex their hand, the harder those finger joints extend.
It's a paradoxical IP extension on attempted flexion. The system is operating in reverse. Why does this happen?
It happens because the FDP tendon has been disconnected from its normal distal anchor point on the distal phalanx. This could be due to a deep laceration in the finger, an unrecognized jersey finger avulsion, an amputation through the DIP joint, or even iatrogenically if a surgeon puts in a tendon graft that is simply too long and has too much slack.
So Any situation where the FDP is cut or disconnected distal to where the lumbrical originates in the palm?
Precisely. Now, think about the mechanics of what happens next. The patient tries to make a fist. The massive FDP muscle belly contracts in the forearm, pulling the tendon proximally. Normally, that pull would translate all the way down to the fingertip and curl it, but the tendon is cut. So the force of that massive FDP muscle has nowhere to go except directly into the delicate lumbrical muscle that is hitched to its side in the palm.
Oh, wow. The force takes the path of least resistance.
Exactly. The lumbrical acts as a biological redirect cable. The entire pulling force of the flexor system is suddenly channeled through the lumbrical and pumped directly into the extensor mechanism on the back of the finger.
That's crazy.
The patient fires their flexor muscle, but the altered anatomy translates that powerful force into an overwhelming extension of the IP joints.
That is incredible. The flexor muscle has literally been hot-wired into becoming an extensor.
Yes, paradoxical IP extension on attempted flexion. That is the exact clinical definition of a lumbrical-plus finger.
Okay, contrast that paradoxical failure with our second one, quadriga.
Quadriga is a different mechanism of failure, but it lives in the same anatomical family of interconnected tendons. The word quadriga comes from ancient Rome.
Oh, the chariots.
Right. It refers to a specific type of chariot that was pulled by 4 horses. But all 4 horses were controlled by a single charioteer holding 4 reins clumped together in one fist.
So the 4 horses are our 4 fingers.
Yes. The index, middle, ring, and little fingers. Now, the key anatomical fact here is that the FDP tendons to the middle, ring, and little fingers are not fully independent muscles.
They share a muscle belly.
They actually share a massive, common, conjoined muscle belly up in the forearm. They are hitched together, like the horses of a quadriga.
So if one rein is messed up or pulled too tight, the whole chariot crashes.
Exactly. Let's say a patient has an amputation of their ring finger, and the surgeon decides to pull the cut FDP tendon distally to stitch it tightly over the bone end to pad it. Or perhaps they repair a lacerated FDP, but they perform the repair with far too much tension, essentially shortening the tendon.
So that specific tendon has now been made artificially short. It is a tight rein.
Precisely.
I think I see the physics here. What happens when the patient tries to make a fist with all their fingers?
The common muscle belly in the forearm contracts, pulling all the connected tendons simultaneously. But because that one injured tendon is tethered or set artificially short, it rapidly runs out of slack. It reaches its maximum possible physical excursion very early in the motion.
It gets stuck.
It physically cannot travel any further proximally.
And because the middle and little fingers are attached to that exact same muscle belly?
The short tendon acts like a biological handbrake on the entire system. It physically stops the common muscle belly from contracting any further, which means the other, completely uninjured fingers are suddenly robbed of their excursion.
Good.
The engine shuts off before they can finish their arc of motion, and they freeze midair.
So the clinical result for the patient is?
The patient presents with a noticeably weak overall grip strength and a visible, incomplete flexion of the adjacent, completely uninjured fingers.
Let me summarize this cleanly. Lumbrical-plus is when an FDP is cut distal to the lumbrical, causing paradoxical IP extension on attempted flexion. Quadriga is when one FDP on a shared belly is over-tightened, causing a weak grip where the adjacent healthy fingers won't bend.
Nailed it.
I'll state that again to lock it in. Lumbrical-plus is when an FDP is cut distal to the lumbrical, causing paradoxical IP extension on attempted flexion. Quadriga is when one FDP on a shared belly is over-tight, causing a weak grip where adjacent fingers won't fully bend.
It's a wrong direction problem versus a stolen excursion problem.
So the core takeaway from this final segment: an FDP cut distal to the lumbrical gives you lumbrical-plus, resulting in paradoxical IP extension, while one over-tight FDP on a shared belly gives you quadriga, resulting in a weak grip and adjacent fingers failing to bend.
Yep.
One more time on that core principle. An FDP cut distal to the lumbrical gives lumbrical-plus with paradoxical IP extension. One over-tight FDP on a shared belly gives quadriga with weak grip and adjacent fingers failing to bend.
That comprehensively covers the core curriculum, the anatomy, the biology, and the mechanical failures of the flexor system.
We have gone incredibly deep today, and if you are listening while driving or on the treadmill, we want to synthesize all these complex moving parts into one rapid conversational wrap-up. Let's do a lightning round.
Alrighty.
If I'm a candidate sitting in the hot seat and the examiner asks me to rapidly walk through the critical discriminators of the flexor system, where do we start?
We start with the architecture, the pulleys. 5 annular, 3 cruciate.
Right, and the critical ones are the A2 and A4, because if you lose those even-numbered pulleys that sit over the bones, you lose your mechanical advantage and the tendon bowstrings.
Exactly. Then you move to the zones. The classic trap is Zone 2, no man's land, where both the FDS and FDP share a tight sheath.
And that's exactly where Camper's chiasma lives, where the FDS brilliantly splits in half to let the FDP pass through to the fingertip. What about the carpal tunnel, Zone 4?
You must rattle off the contents without hesitating. 9 tendons, which is 4 FDS, 4 FDP, and 1 FPL plus the median nerve.
Then we get to the OR repair strength. It's not about the locking knots, it's about the number of core strands crossing the repair site.
Yes, core strands dictate strength. And you maximize your biology by promoting intrinsic healing via tenocytes, avoiding the extrinsic adhesions caused by fibroblasts and heavy hand and surgical technique.
And we push that intrinsic healing during the fibroblastic phase using early motion. Dynamic motion for Kleinert active extension, passive flexion, and passive motion for Duran.
Unless it is a pediatric patient under 5, in which case you immobilize them, but critically not beyond 4 weeks.
For surgical retrieval of a retracted tendon, we never use forceps. We use a pediatric feeding caster to respect the synovial lining.
And for clinical scenarios, jersey finger is your classic ring finger FDP avulsion, classified by Letty and Packer. A chronic FPL laceration with a supple joint demands a ring finger FDS transfer.
Which leaves us with the paradoxes. Lumbrical-plus is paradoxical extension because the cut FDP pulls the lumbrical. And quadriga is the handbrake effect, where one tight FDP on a shared belly stops the adjacent fingers from bending.
If you can converse fluently about those points, you understand the flexor system on a fundamental level.
Absolutely brilliant synthesis. You know, the magic of an audio deep dive is that you don't have to absorb it all at once. If you are sitting your surgical exam soon, let this play again on your commute. Let the biomechanics, the rules, and the cellular biology sink in until discussing moment arms and intrinsic healing becomes second nature.
It's the best way to integrate complex biological systems. And speaking of complex systems, I'll leave you with a provocative thought for your next study session. We spent this entire deep dive talking about the rope and the rings on the palmar side of the hand.
The flexor side.
We touched briefly on how the lumbrical acts as a bridge, carrying force over to the back of the finger. So what happens on the other side? What happens when the central slip or the lateral bands of the extensor mechanism fail?
Oh, that is a whole different beast of biomechanics.
It truly is. When you start thinking about boutonniere versus swan neck deformities, and the clinical tests like Elson's test or Boy's test that separate them, you enter a new world. The extensor mechanism is arguably the most intricate, geometric, sheet-like structure in the entire human body. It is just waiting for your next deep dive.
We started by looking at a simple rope through a tunnel of rings, and we ended up dealing with chariot reins, hot-wired muscles, and biological handbrakes. Keep studying, keep reviewing those anatomical pathways, and we will catch you on the next deep dive.